Welcome to Spine Conference. Today's discussion is a little different. It's going to be a review of all the of some of the posters that I found interesting at the Academy. So, you guys been to the Academy? So the Academy has, I don't know, maybe 500 posters, and they're just these big 3 foot by 5 foot posters that go over a research article. And what's nice about it at the Academy is you can do it on your own time and you can spend as much time as you want reading about it. So I like it. It's a nice thing. And they have them on these boards and people just walk around. And sometimes the people who made the research is standing next to it and they can talk to you. It's very nice. It's one of my favorite things to do at the Academy. And the Academy has many things to do. That's just one of them. But um, so I take pictures of the ones that I find are interesting, and I thought maybe we'll go over them. So, as always, if you guys have any questions, just please interrupt me. Um, so this one is this is a study of cross-sectional anatomy of the spine and whether it makes a difference how big your muscles are on your back as far as, and compare it to uh, disability. So it was done at Thomas Jefferson. So let me just go over a couple things. I think of the spine as a column, the body as a column. Can you see? Does that look like a column to you guys? And you see how it supports the torso. And and the way I think of a column is there was like an architect school. My friend in college said in architect school they told people they gave them a piece of paper and they said how can you make the strongest way to hold up a structure with this piece of paper? And you say it's impossible. You can't hold anything with a piece of paper. It's just a piece of paper. Not if you fold it up into a column. If you wrap it around into a column, it can hold something up, right? It's a very strong function. Yeah, see that? I mean, it works. And it's a hollow column, and that's why our bones are hollow columns, like our femur. Yeah, think about it. I mean, you could probably put a 10-pound weight on that, and that's pretty impressive. So, yeah, so columns are very strong functional objects that can hold weight. So, I mean, the most obvious column structure is I like the Parthenon because I'm Greek. And you can see it like a hollow column is very strong too. So I look at the our torsos as a column, and if you can strengthen the column around the periphery of our bodies, it takes the stress off the spine. I mean, does that make sense to you guys? And that's what I think. Does anybody? What do you think? Um, you agree? What do you do to strengthen people's torsos? Transverse abdominis. Uh-huh. Like the transverse abdominis and the obliques. So so can you just? I know it's if you can you summarize some exercises that are good that you do? So it's like so isometric strengthening. Hmm. Okay. So so you can imagine if you have a very weak um, core, all of the weight of your body is borne by the discs. And good morning, Alan. And anyway, those are my thoughts. And then if all the weight's borne by the discs, there's higher stress on the spine, and the discs can deteriorate and have problems. So in this study, they basically took a cross section at the L4 vertebral body and looked at the size of the muscles around the spine. So the P is a psoas, and the posterior erector muscles, the iliacostalis, longissimus, multifidus, that's been studied, and that has been shown that if you have weak back muscles, it's a poor predictor of surgical outcome. So if the muscles of your lower back have a small cross-sectional area, it's a poor predictor. This study was looking at the psoas. So they looked at one level lumbar fusions, and they did it retrospectively, 101 cases. And they found that patients with a small psoas cross-sectional area were more likely to have severe disability. So the difference was around 15%. I put the little percentage in there. The difference was around 15%. And it made a big difference. And the disability was defined by this Oswestry Disability Index. It's basically on the bottom, you see the 10 categories: pain, personal care, lifting, walking, sitting, standing, sleeping, social life, driving, riding a car, change of pain. So 10 questions. And for each question, you can see, like section 4, I put walking. You can just see the question, like, I have no pain when I walk, I have some pain, and the worst one is I cannot walk at all because of the pain. So this is just a questionnaire to get an idea of how disabled you are amongst these 10. So the people that had a small psoas were more likely to have severe disability. And the other interesting is people with severe disability were much more likely to be smokers, 34% versus 16%. And people with severe disability they're just sicker people. They had a higher ASA, which stands for American Society of Anesthesiology. Here's the American Society of Anesthesiology classification of how basically how sick a person is. The people who were more disability were more sicker people, which that makes sense too. So I just did a little Google search of how I can strengthen my psoas. What do you think of those exercises? You like those? The V, there's no way I can do a V. I used to do Vs. Those are really hard. And the other one, the Setu Bandha, that thing, you think that's good for core or no? But I can definitely do the top right one, just sitting in a chair, go backwards a little bit, and that's kind of like a crunch. And the other one I think is pretty easy too. Just lift your leg lift sort of with the. Well, I think they do that also to stretch your hamstrings. The whole exercise. I can go 90. I can go close.
Where's the old plank besides the last one?
I think the plank's good too, right? The plank. Yeah, it's an isometric, and isometrics are good because they don't flare up your spine. So this was I thought it was a somewhat interesting just study that the core musculature is a very good predictor of how disabled somebody is. Now, what comes first or second? I mean, it's not causative; it's just correlative. So who knows? What the relationship is. So any questions about that last one? Okay, so the next one is this is just a study of interbody fusions amongst orthopedic surgeons and how do they fuse it. And over 10 years, they just studied data of what codes did surgeons code, like how did they take care of the patients, and they basically look at billing records. And it studies basically anterior lumbar interbody fusion versus interbody fusions. And just so you know the difference, this is an anterior interbody fusion. That's the one I put in on was it Tuesday? What's it called again? Oblique posterior atraumatic lumbar. And so it's peak. It's got those little metal. What's it called? Tandem markers. And it shows you where it is in the X-ray, and it goes into the front of the spine. And you can see, I did this. You can see how it gives instant stability to the spine by increasing the interbody distance. It puts a little bit of tension in the front of the spine, anterior portion of the spine, and then the pedicle is compressed from the back. It makes it very strong. And the other thing it does is that it opens the frame, and so this is the frame in here where the nerve lives. And you can see if you put something in the front, it jacks open that frame and gives the nerve plenty of room. So that's sort of the function of the interbody graft. And this is just a recent case we did this week. Just it's a very good example. As you can see, this patient has a very unstable spine. You see the fracture there in the pars
Yeah.
and the sliding. And then in her, here's the lateral view. You see how this opens up the frame and it gives instant stability, and you can see the little markers. Yeah. So it's nice. It's nice to understand what things are and look at them, retrospectively after you put them in, so you know how to think about it. So it's an interbody graft. So the the study just shows the use of the interbody grafts, and it's over the years it's slowly increased. Interbodies came out like they became very popular in the first one was the BAK cage, I think, or the Bagby cage. They was like late 90s as they started becoming very popular, or like middle 90s. And the first one, maybe the Harms cage was one of the first ones. Um, and it just has increased. So I think it's just this is just a function of this new technology came out, and just more people are using it, more people are comfortable with it. And the other interesting thing about this article was complications from anterior versus posterior interbodies. The anterior, you cut someone's belly open and you go through the front of the spine to put it in there, and posterior is through the spine. And the biggest difference is the anterior approaches, you do have a chance of a vascular injury. That's what's circled. So, and those vascular injuries are very, very serious. They're the inferior vena cava or the iliac vein. They can be very dangerous. You can lose a lot of blood very quickly, and they're difficult to control. Um, but otherwise, the complications were similar. There's twice as many interbodies than there were anteriors. Um, so these are just the complications. They're all kind of similar because there's twice as many interbodies. So even though the numbers are different. So any questions about interbodies or just more popular? Okay, this is something I struggle with all the time. This was a Maimonides, just a discussion of when patients can go back to driving after surgery. Does anybody have any opinions about this? You're nodding. What do you think? Yeah, just defer the physician. Yeah, yeah, yeah. How strong they are before. Yeah, and we know. Yeah, there's a lot of factors, and it's also range of motion of people, and everybody's different. A 21-year-old is different from an 81-year-old. Yeah, I don't. So I don't know what to do about this because people ask me all the time, and I don't want people to be housebound for no reason. So this was just an interesting just a discussion about it, and they have different ways where they study it. They study it with brake response time, so they can just see how fast someone can put their foot on the brake when they see something in front of them. And the other one is detection response task, is that people see something and they respond to it with their hands or something. These are the ways that in research they study these things. And just the ballpark, this was just a discussion. There's no standardization to this. I mean, basically, the one number that I took from all of this information was 6 weeks, you're good. But no one wants to stay home for 6 weeks. I mean, nobody does that. And you can't tell. I mean, and some people do listen to what you tell them. So it's kind of important. I mean, I usually use a week or two. Um, I don't know, but most people want to go to the grocery store after a week or two, or they want to go to work. Um, So I kind of throw it back to the patient because they kind of know themselves. I say, look, you have to be good. You have to be able to drive. So I basically say, drive around the neighborhood and test yourself and see how you are. Usually it's a week or two. Well, what do you think? Much. Yeah, but a lot of people, they have to go to the grocery store to get food. They have to go to work. I don't know what to tell these people really. So I mean, I don't want to be one of these doctors that say 6 weeks or 3 months. I mean, they're going to lose their jobs, and it's taxing on their families. So I'm not sure what the right answer is, but the and everyone, it's basically the responsibility goes back to the doctor, and the doctor usually puts the responsibility on the patient. So I'm not sure what to do.
We create a mock-up driving seat situation and measure the time um, but I was looking at how fast does the patient, how long does the patient take to get to the brake pedal or
Break
some other
response,
maneuver?
yeah, break response time.
Yeah, which is mentioned on
Yeah.
there. Yeah.
Most people, I think that it's like 2 weeks, people are okay. But like in cervical spine, most people say they go back to driving in a week in this study. At 6 weeks, they're totally fine. Um, in 2 weeks, fusions, people are better than they were pre-op. So I think the ballpark number is 1 to 2 weeks. But I don't know, there's medical legal implications too. And
Yeah.
so I mean, if the people crash their car or they kill themselves, or I mean, I don't know if any of you guys have ever had a spasm. Have you guys ever had a back spasm when you're driving? It
Yeah.
happened once to me on the Beltway. I couldn't turn. I couldn't turn to look at like a truck or something. I was disabled. I pulled off of the first exit and just relaxed until the spasm went away. So you can imagine if you had spinal surgery, it's more likely to get a spasm. Anyway, I thought that was interesting. That has to be somebody should study that. No, no, this was not even a study. This was just a review of the literature and a discussion of what's out there for driving after surgery. Okay. This one, um, I'm sorry you can't read the top there, but this one is the title is Surgery Related Factors, More Than Patient Related Factors, Increased Risk for Postoperative Urinary Retention After Elective Laminectomy. So basically, I do a lot of lumbar decompressions, small surgeries, and usually the people are somewhat older. And the question is, are they going to have post-op urinary retention? So post-op urinary retention, I'm always thinking about it every single day, right? We talk about it constantly. Does this guy get a Foley or not? So in the past, what I have done, and I'm going to change my practice now after this article, is men over 75 get a Foley. That's been my number. I don't know where it came from, but just because of prostate. So this was really interesting. There's 1 and 2 level lumbar decompressions, and they studied who is at risk for having urinary retention. And there was a lot of patients, 421 1 levels, 252 2 levels, and very interesting findings. Um, so a 1 level and a 2 level is a lot more likely to have a problem with a 2 level. So half of the people had urinary retention, and a third with a 1 level. And surgical time was the biggest factor. So the longer the case, 2.5 hours, a lot more likely to get it than if it's just 1 hour. Um, and if you have urinary retention, you stay in the hospital a lot longer, 3 days versus just 1 day. But the most interesting finding is for me was age and gender had nothing to do with it. So I was totally wrong. So it doesn't have, it just has to do with the length of the procedure. So I don't know. Well, the longer the procedure, the more fluids you give, by definition, always. Yeah. I mean, that's a factor, the length of the procedure. But also, I mean, my takeaway is I'm going to still do the same thing. 75-year-old men get the Foley, but I'm going to add women now because because we have had women too. So the longer the procedure, women get urinary retention as well. If you have a catheter, the other thing is I tell people is if you have a catheter, it puts you at risk for infection. So a lot of these people, men and women, call me and they have a urine infection, and that's a problem too. I mean, you can get very sick from a urine infection.
It was a big issue in ICU. It's a big movement to not put photos of
to monitor urine output. You can monitor urine output if the patient, if they're not awake, yeah. Yeah, sick patient, yeah. You just put like a Texas catheter in it.
Did they follow up on the male patients to see if they had pre-existing prostate disease?
No, they didn't. It didn't. It didn't. I don't think so. I think for 2 or 3 levels, I'm gonna leave it post-op, 24 hours.
What about a permanent problem?
Rare, but some people get so upset if they have to have a catheter for 2 weeks. I mean, they have to walk around. Usually, it's like a couple of weeks, 2 weeks.
Really?
It's, women don't have as much of a problem. I've never had a woman have a long-term problem post-op, but I had a couple of men that just had serious, not serious problem, but a week or two. You have to walk around with a Foley bag. It's very uncomfortable. And they just had pre-existing, prostate hyperplasia that was undiagnosed. Okay, so post-operative urinary retention. Let's keep going. Next is a problem that I get a lot is this is studying risk factors of adjacent segment fracture after balloon kyphoplasty. So the basic problem is patients have a fracture of the spine, you do kyphoplasty cement for them, and then they fracture again. And then you do it again, more cement, if another fracture, more cement. So the question in my mind is, should we be even doing this in the first place? I mean, it's just, and who gets this? So this is an interesting study where they studied who are the patients that keep getting fractures after kyphoplasty. So I think this is it's a good thing to study. So the basic problem is you do kyphoplasty and then the next level fractures. And so balloon kyphoplasty is it's very interesting that a general surgeon developed this, and it was a transformative change in healthcare. And they say that when the biggest changes in technology always comes from outside of the field. So it wasn't a surgeon, orthopedic surgeon, or neurosurgeon, or spine surgeon that did this. It was a general surgeon who came up with this idea. So you have a broken bone, and you use a small tube, like a catheter, a small metal tube, put it into the vertebral body. Through that tube, you have a long catheter with a balloon on the end, and the balloon opens up in the bone. And then you inject the cement into the void that's created. So initially, the thought process was the balloon makes the bone bigger to recreate the size of the bone. It doesn't work, really.
No, it hasn't worked out.
It doesn't work. It doesn't do that, but it does. Yeah, it doesn't work, but it does make a void so the cement stays in the spine and doesn't go into the spinal canal. Because when obviously, if the cement goes in the spinal canal, you have a neurological injury. It's a disaster. And also, the cement can go into the veins and go into the lungs and cause a pulmonary embolism. What's a medical pulmonary embolism, which is a serious problem too. So the balloon is good for that. So I always use the balloon because I want the void so the cement goes where the void is. So did I explain it? The balloon kyphoplasty?
Yeah.
And the cement. And the cement was originally created for tumors, because to cut someone's abdomen to take a tumor out of the bone, that's a very big operation for someone. But this was made for tumors. The tumor destroys the vertebral body, and you just stick cement into the vertebral body and make it stronger. That's how it was developed. It was developed in France. So it's a very good technique. Okay, so who recurs? So I'm sorry that this is not clear, but the big bar are the fractures, and the little bar are the recurrences. So you can see the people who recurred were at the thoracolumbar junction. And that makes sense because where the ribs and the lower back meet, that's an area of force, because the ribs make the spine stronger, and the lumbar spine is more mobility. So it's an area of stress. So thoracolumbar junction are the people who keep having fractures. And then the other thing is they measure the angle of the vertebral body before and after, and they call it both segmental and vertebral angle. I think vertebral angle was the vertebral body itself. You can see the dotted line, and the segmental is one above and below. And they found that the people who had a bigger angle were more likely to fracture the next level. It wasn't that big of a difference. It was between 17 and 23. So So the more crooked the bone is, the vertebral body is, when you do the kyphoplasty, more likely that you'll get another fracture. So that may be a proxy for osteoporosis, I think. So because if you fracture the spine and it gets crooked, it means it's weak. Because if you fracture the spine and it does not go crooked, it's a strong spine. So anyway, I thought it was a little bit interesting. Okay, any questions about that? So this is I selected this one because I know Tony likes to watch the NFL on the weekends. And this was a study of NFL scouting base between 2009, 2015, 6 years, of the influence of cervical spine injuries on these young kids in college and how they do in the NFL. So in other words, you look at all the kids coming out in college and see who had the cervical injuries, the neck injuries, and then you see how did they do in the NFL, these people. So I mean all these NFL articles, I don't think they help society, but for football fans, they're fun to talk about. And interesting because a lot of kids are in college and they play football. So basically, the injuries 4 to 1. There's 4 defenders for 1 offense player. So it's a lot more likely to get a neck injury if you're on defense, and you do much worse if you also had a concussion, which makes sense because it's probably a bigger injury if you have both a concussion and a neck injury. And then the cervical injury players did much worse as far as when they were picked in the NFL, and they started fewer games and they played fewer games and they didn't last as long in the NFL. So basically, if you are coming out of college with a neck injury, you're probably not going to do well in the NFL. It's a very poor prognostic indicator.
That is the fact that when you're being screened for such,
Well, I'm sure all the owners, yeah, look at that.
they all have a history of physical.
Yeah,
Yeah.
and history. And the other thing is a lot of people have undiagnosed small spinal canals, cervical stenosis, because the area for the spinal cord varies, and some people have very small areas. So what happens is these kids, they have a small area for the spinal cord, but they haven't been tested. And then now you're throwing them in a Division I football game, and they're really hitting their heads and necks, and they get problems. These kids, and my personal opinion, they're not destined to be football players. They were born with this weakness, this basically like a tragic flaw, and it's unfortunate. You can also you can see how big the spinal canal is on the X-ray too, on a lateral view X-ray. It's called Torg ratio. You measure the vertebral body and the spinal canal, and you can sort of guess, and it makes sense. Okay, this one I found really interesting. It's about the opioid epidemic, and how can we how can we this is the basic. There's a couple premises. One is the opioid epidemic is a disaster in our country. Last year, I think 42,000 people died, which is a lot. It's gone up like 5 times since like in the last 10 years. We've got this terrific epidemic. The worst state is West Virginia. People, and Harford County has gotten the problems. I mean, a lot of people are dying in Harford County. So, and then the third highest prescribers of opiates are orthopedic surgeons. And the reason is when we do surgeries, people have painful problems, and we give them pain medicine. The other problem is orthopedic surgeons. We don't know how much pain medicine to give people. Most people just take pain pills for 3 or 4 days, but some people take pain pills for 3 months. And if people don't have the pain medicines, they're constantly calling the office. They're coming back. It's a lot of work. So the natural response for many surgeons is to give everyone a huge bottle of pain pills so that there's no phone calls afterwards. The problem is this huge bottle of pain pills is abused by either the patient themselves or a family member. So it's a problem. So the question is, can we somehow know who needs the pain pills and who doesn't? So this was an interesting study. They studied pain medicine after knee replacements and hip replacements, and also a way maybe to measure it. So what they did is they used. You guys ever seen this algometer? So Yeah, I want one too after reading this. So basically, you put this on someone's body and you put pressure on it and you say, "Tell me when it hurts." So you've got someone like Erin who's very stoic, and she's like probably like she got really high pain threshold. She says it doesn't hurt all the way up to 20, but
You
then
have to work.
right, she has to. I know. Otherwise, they're self-selected. And then you got somebody who's Tony, who's a real sissy. He'll start crying when it's like 3. So the premise of this is like Tony's going to need a lot of pain medicine because preoperatively we did the test and he can't take any pain. While Aaron's not going to need any pain medicine at all. So this may be a good way preoperatively to see who needs the pain medicine and who doesn't. I think it's really smart and it's interesting. And so they tested everybody, and it's called the prospective pain threshold (PPT), and it was very variable. You see, like the far right are the ranges. You see, the range is huge, and and the threshold did correspond to how much pain pills they took. So it may be a nice tool for us to use. So these are just a couple of statistics. Is 20% of the people, 1 in 5, took the pain pills from the doctor and then went to another doctor to get more pain pills, whoever that may be, the ER or whatever pain manager. And the average was 125 oxycodones in 6 weeks. I found that very interesting. That was higher than I would expect for knee replacements and hip replacements. Don't you think? You think that's about right? That's a lot of oxycodones. Some people come in right away. I know. Some people come in 2 days. It's an average, yeah. And days required were 30 days, which is interesting. These are all. This was the average, and the range, was 0 to 42. Some people didn't need any pain medicine at all. Some people longer. Um, so I thought this was very interesting. In fact, I'm thinking maybe I should do it. Get this algometer, cause yeah, and test everybody. And the people who say that doesn't hurt at all, they need 10 pills and they're good. And the people who, the minute they put it on there, they have severe pain, and this person is going to need a lot of pain medicine. And that way we don't give out a million pain pills to everybody. Actually, I think I should do it. It'll save us a lot of grief. And it's in their chart. What do you guys think? Don't you think it's interesting? It's very interesting.
Well, what are the statistics on how well the device works? I mean, what's the outcome with this device? Does it work?
It works, yeah. It predicted pain pills. It predicted how they're. That's the whole point of this is
Right, I understand.
can we predict who needs it and who doesn't, so we don't have all these pain pills out there in society. Yeah, well, that not in this study, but that's been proven. So people who come in preoperatively who are already taking opium, a lot likely need a lot more opium post-op. And those people who are preoperatively on opiates are don't do well. They have a lot of pain. They have problems.
Skeptical.
Why? Tell me why.
I don't know. That's pretty skeptical.
That it's effective.
Apply a device using it.
That's an effective measure of pain.
Too many variables, too much going on. Suppose the patient has peripheral neuropathy.
Then it won't work. It won't work for those patients. It may not work for diabetics either. They can't feel anything. On me?
Yeah.
Oh, on Dave, yeah. We'll try it on everybody.
You combine this, there's this smiley faces. Or you say the patients well on a scale of 1 to 10.
Yeah.
1 being nothing and 10 being the worst pain you can
Yeah.
Did they use that with this?
I think they did, yeah. I think they did. It's called visual analog scale. I mean, when they ask me visual analog scale, I don't even know what to say. Do you know what to say? I was like, I don't know.
There could be psychological effects of using the instrument, and someone really smart would say, "Boy, I want a lot of pills, so I better say, press
Well,
on a little bit."
when they gave
Whoa,
this,
that really hurts,
You don't have to
doctor.
tell them what
I mean, people are going to game the system.
And there could be something there could be a way to ask them when it hurts, whenever 50 or 20 or whatever the number is, team number. But I mean, always caring, how does everyone feel at a certain point?
It's just a test. I mean, the other test they've done is the blood pressure cuff. They put a blood pressure cuff on your arm and pump it up to 200 millimeters mercury and see how long you can last with it on your arm. That's another way to see how sensitive you are. And they found that this was a fascinating study they did with people who are on opiates like hydrocodone. If you're on hydrocodone, it makes you very sensitive to pain. So what happens is when you're on opium,
That's the phenomenon, yeah.
makes you more and they've proved that with the blood pressure cuff. So that's why pain pills are not good for you. They just make you more sensitive to pain. It's counterintuitive. I tell the patients all the time, is like the reason why you're having pain is you're on opium. If you come off the opium, you'll be able to deal with pain better. But that doesn't make any sense to people.
Also,
It's counterintuitive, yeah.
there are other parameters that are really important. For example, addictive potential.
Yeah. Those people, yeah, like some people have no addictive potential, and some people have
That's right.
unbelievable addictive potential. And it was very variable, yeah. Yeah, they did like what's it, a study on a functional brain MRI where they gave people it was alcohol, like a
Mhm.
shot of alcohol, and a shot of
Yeah, they
alcohol
studied
was
that.
it was a tremendous difference between people. Like some people, their whole brain lit up on the alcohol. Those people were addictive potential, and some people it didn't affect the brain at all.
That's right.
So it's
Some people really have addictive potential.
yeah, some people are they're just born like that.
If somebody comes in who's a heavy cigarette smoker who's never been able to stop, that's the red flag, isn't it?
Yeah, yeah. It's definitely a piece of information.
There's a great book called Drug Dealer MD. It's paperback in the library. It's 125 pages about how prescribing habits by doctors, particularly in West Virginia, led to this opioid addiction outbreak.
Drug dealer MD.
Yeah, I can't remember the author's name.
Well, I mean, you remember, weren't you practicing in the 90s when it was like the fifth vital
Yeah,
sign,
yeah.
and if people can't have pain medicine, and these new medicines are not addictive, and
The Joint Commission used to come around and say, how many of you have bad mark against you?
it's a big
There's
deal.
tendency to overprescribe.
Yeah.
Well, that hits home with us. You know whom.
Yes.
It was anyway, but now we're going the opposite direction. So okay, let's keep moving. This was a this was an interesting thing. Is like basically you do a decompression, take the pressure off the nerves in the spine. Who fails? Like which patients go on to fusions? So, I mean, this has been studied many times, but this is just one more. This was done in Japan. So basically do a lumbar decompression, take the pressure off the nerves, and then which patients don't do well and which patients uh, go on to fuse, the need a fusion. And the patients that failed, 10% of patients failed. The most common one was foraminal stenosis and disc herniations and facet cysts and sagittal imbalance. But the biggest one was 14 patients were foraminal stenosis. So I just want to, and the other one was people who had a preoperative vertebral slit, patients with spondylolisthesis. I just want to show on the bottom left is a case of foraminal stenosis. The frame, and I tell patients, is the hole where the nerve exits. And I'm going to show it to you. This is the foramen, and the dot in the middle is the nerve. And you can see below that, there's a disc hitting the nerve. So patients who have foraminal stenosis fail. And on the next one is an MRI of foraminal stenosis. And it's very difficult to decompress the foramen without fusing it. So this makes a lot of sense. Um, it's just so foraminal stenosis and spondylolisthesis. So patients with both foraminal stenosis and spondylolisthesis, I'm a lot more likely to recommend a fusion. I mean, depending on the situation, of course. Okay, this one I thought I thought very interesting. It's basically people who have revision spine surgery for whatever reason, and there's implants in the spine. And what this doctor did, there's one doctor in Texas, at the Texas Back Institute. He took all the screws and cultured them, and he wanted to see was there an indolent infection in the screws. So let me explain this with pictures sometimes. So here's a patient that see how the screws are a bit loose and they're having symptoms, whatever reason, no signs of infection. You take out the screws and see if there's bacteria in the screws. I mean, yeah, of course, you know where the story's going. So this is, do you guys know about my bucket? I started this 10 years ago, and this is basically whenever I take a screw out of someone, I clean it very well and I save it. And when the story started, I said when the bucket gets full, I'm going to retire. It's getting very close, so I think I'm gonna have to get a bigger bucket. But so you take these screws and you culture them, and you see what happened, and the results are very interesting. First of all, let me show this. Preoperative testing was not helpful. So did SED rate, C-reactive protein, procalcitonin, these inflammatory markers, were they helpful to see who was infected? The answer is no. There was not really that helpful. So and then what were the results? The results were 9% had a bacteria in the screws. And the bacteria were on the bottom there. I'm going to say this wrong. Propionibacterium acnes and Staphylococcus were the most common. The Staphylococcus, we know that. That makes sense. That's it, you know. But Propionibacterium acnes, that I raised my eyebrows like, what is that and what is that? So I mean, it's basically the bacteria that's found in that causes acne. It's a gram-positive rod, and it's part of our skin flora. And it makes sense. It's just and it's a slow grower, so it's an indolent infection. And I assume the Staph aureus was not MRSA because MRSA patients are sick.
I was going to say, cool.
Yeah, they're sick patients. They usually present as infected.
The only thing is really just colonizing.
Right. I mean, the definition is of an infection is a symptomatic colonization, right?
If the time the screws were taken out that was positive, was there any sign clinically that an infection?
No signs. But what do you do with this piece of information? I mean,
Ignore it.
maybe.
Don't call it.
Yeah. Well, there's bacteria everywhere. I mean, if you take cultures of our bodies, there's bacteria in the fat. You can find it in many places, and it's usually indolent. It usually doesn't cause a problem unless you get stressed, maybe. I don't know. I thought it was interesting though.
Did they recommend it?
No. Okay, this one I found interesting, and I apologize from the beginning. It's not spine, but my opinion. Do you guys know Charlie Munger? Charlie Munger. He's the what is he? He is the Warren Buffett's
Oh yeah,
buddy.
yeah.
Okay,
Huh.
and he's an unbelievably intelligent man. He's one of my heroes, and one of his common statements is to understand the world, you have to have a vast breadth of knowledge in many fields, be it psychiatry, engineering. You can't just be just focused on what you do because you'll miss a lot of things in life and you'll make big mistakes. So you have to cross-pollinate yourself constantly. That's why I go to the academy. I like to look at different things. So I found this fascinating, interesting is marijuana use minimizes patient-reported pain following lower extremity gunshot wounds. So this was very interesting. This was an urban study, and it's people who were shot. And then they looked at people, how they did pain-wise. They looked at the people who smoked pot and the people who didn't smoke pot. And I'm not sure actually. Just marijuana use is probably smoking, but I don't know. I'm not sure if they looked at that, how they took the marijuana.
Brownies.
Maybe it was brownies.
Well, we all have cannabinoid receptors on our brain. So,
Yeah. Well, let's go. So they lost a lot of people to follow up because just the nature of the business, gunshot wounds, they don't come back, and they're usually young people. A lot of times they're young people. So it's 26, 28 years old. There are 5 marijuana users and 45 non-marijuana users. And the interesting fact is the pain scores, look at the bottom, the people who smoked marijuana had no pain. They didn't say they had pain. The people who did not smoke marijuana complained of pain and needed pain pills. So it was 133 patients, so a lot of them were lost. 50% came in follow-up. So 20% of the non-marijuana group are still using opiates, but nobody who smoked marijuana was complaining of pain. So interesting.
I think
Hmm?
somebody doesn't turn off, or small numbers.
Small numbers, I know.
Yep. Interesting.
Yeah, it's interesting, but I definitely think there's a role for marijuana with chronic pain patients. It's probably less of a toxic drug than oxycodone.
Did anyone have tested to see if they had any opioids or anything else?
No, this is just talking to people.
Yeah. Because our experience on the ICU is if somebody comes in there after you're like, you often find marijuana in there. So these are people using
Multiple, yeah,
Yeah.
yeah. This is again, this one has got nothing to do with the spine, but I just really liked it. I really like thinking about it. What happens a lot is people with total knee replacements, they're infected, and you don't know if they're infected or not. And it's a serious deal if they're infected. So instead of culturing the synovial fluid, this is an immunological test which specifically tells you if you have the antigen for the bacteria, and it's very sensitive. So like they look for Staphylococcus, Candida, and Enterococcus, and the this is the negative people, and these are the positive people, and this is a logarithmic scale. So it's very obvious who's positive and who's negative, and it tests for the antigen. So it's just like a strep test that tests for the antigen. So it's interesting. So we know they're colonized, and you know right away. So that's very helpful if you know someone has a bacteria in their body somewhere instead of growing it. Did you think that's interesting? We could use as many clinical applications for that. And you would want to know that if there's like something has a bacteria in it.
Is that what the false positives and false negatives were?
Uh,
Rates?
it's very low. I don't know the exact numbers, but
This is just
this
synovial fluid.
is synovial fluid. This is what we care about. But obviously you can use this for anything. So that's in the future. Is that
Yeah.
it's a better way to know if there's the bacterias in there. So that's the last one. So anybody have any questions or comments?
Where was the meeting?
New Orleans. It's one of my favorite places to go for the meetings. They go to New Orleans, they go to San Diego, which I don't go. It's just a really long flight. They go to Las Vegas a lot. Uh, Sometimes Chicago. Chicago is one of my favorite ones.
I have a comment.
Yeah.
They use such a large percentage of the population has chronic pain,
Yeah.
and a large number of large proportion of the population starts using marijuana for their chronic pain.
Yeah.
There are going to be consequences which we haven't seen yet. I'll tell you.
Well, I know. I mean, this is a different topic. I know, but me personally, I mean, I don't want my children using marijuana, and I don't want them exposed to it. Um, I want them to be, everyone wants their children to be happy, productive people in their lives, But but there's a couple statistics. I mean, first of all, half of they estimate half of the income for drug dealers comes from marijuana, and that's like a serious problem in Baltimore, like massive problem, drug dealing. So if you could take away all that and watch it, um, and and the thing is, I think marijuana is a lot safer than opium. I mean, it's being tested right now in Colorado, in California, in Washington. And my friend who lives in Boulder, He said so far the only thing that has increased is fatal traffic accidents. That's up so far. So we have these experiments going on.
What one is? What you said?
Legalized marijuana in Colorado. That's like I think they were the first, weren't they?
Yeah.
So it's a natural experiment.
There are more traffic. Fatal traffic.
Yeah, yeah, slight increase.
Crime rates haven't.
Things have not changed that much.
Well, and if there's a way to control the product, because marijuana versus in the 70s and 80s, marijuana is so concentrated, it's actually addictive. In the 80s, it wasn't addictive. So
More concentrated.
it's more concentrated.
Even a pill, Drobanol. Drobanol is marijuana pill form.
Yeah,
Or
no, I asked
cannabinoid.
my friend who's an oncologist because I mean my dog had cancer and my dog's dead now, but wasn't eating. I was like, why can't I get her to eat? I said, what do you do to get people to eat? Cancer patients to eat? He said, marijuana. So I give them. It's not the marijuana on the street, but there's the medicinal. He says it really helps with them, with the patient. They eat, and they keep weight on.
So he gave it to you.
No, I didn't. I'm not gonna mess with a controlled substance for my dog. No, we are when we stop. Well, I'll stop.